Hello everyone, welcome to 2-Minute MRCP. Today we'll quickly review gestational diabetes. Diabetes in pregnancy may either be pre-existing diabetes or diabetes that develops during pregnancy, known as gestational diabetes. It complicates up to 1 in 20 pregnancies. According to NICE, 87.5% are gestational diabetes, 7.5% are type 1 diabetes, and 5% are type 2 diabetes. Gestational diabetes is the second most common medical disorder complicating pregnancy after hypertension. It affects around 4% of pregnancies. Risk factors include BMI greater than 30, previous macrosomic baby weighing 4.5 kilograms or more, previous gestational diabetes, a first-degree relative with diabetes, South Asian, Black Caribbean, or Middle Eastern family origin, and unexplained stillbirth in a previous pregnancy. Screening is done using the oral glucose tolerance test, or OGTT. Women with previous gestational diabetes should have an OGTT as soon as possible after booking, and again at 24 to 28 weeks if the first test is normal. NICE also recommend that early self-monitoring of blood glucose is an alternative to the OGTT. Women with other risk factors should be offered an OGTT at 24 to 28 weeks. Diagnostic thresholds for gestational diabetes are fasting glucose greater than or equal to 5.6 millimoles per liter, or a 2-hour glucose greater than or equal to 7.8 millimoles per liter. Management should begin quickly. Newly diagnosed women should be seen in a joint diabetes and antenatal clinic within 1 week. Patients should be taught self-monitoring of blood glucose. Diet and exercise advice should be given, including foods with a low glycemic index. If fasting glucose is below 7 millimoles per liter, start with diet and exercise. If targets are not achieved within 1 to 2 weeks, start Metformin. If control is still poor, add insulin. Remember, gestational diabetes is treated with short-acting insulin, not long-acting insulin. If fasting glucose at diagnosis is 7 millimoles per liter or more, insulin should be started immediately. If glucose is between 6 and 6.9 millimoles per liter with complications like macrosomia or hydramnios, insulin should also be offered. Glibenclamide is only used when metformin is not tolerated or insulin is declined. For women with pre-existing diabetes, encourage weight loss before pregnancy if BMI is above 27. Stop oral hypoglycemic drugs except metformin. And commence insulin. Give folic acid 5 mg daily from preconception until 12 weeks gestation. A detailed anomaly scan should be done at 20 weeks, including cardiac views. Tight glycemic control reduces complications. Retinopathy should also be monitored carefully because it can worsen during pregnancy. Target glucose levels are fasting glucose 5.3 millimoles per liter, 1 hour post-meal less than 7.8, and 2 hour post-meal less than 6.4 millimoles per liter. And that's gestational diabetes in 2 minutes. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.